Having only completed his PhD in 14, he already has 15 manuscripts, so he's well on his way to deserve that Rising Star Award. And I look forward to hearing his research today. So please join me in welcoming Dr. Larimer as he tells us about using PET imaging of immune activation in tumors to enhance tissue-based analysis. Thank you, Dr. Larimer.
Thanks, Adam. I really appreciate the opportunity to talk to you guys today. Yeah, so I'm in the Department of Radiology, and you guys are going to have to forgive me because, you know, when we talk about imaging, with you know, it's all in vivo imaging, but I fully appreciate that pathology has been doing imaging for a lot longer than radiology is. So when I'm talking about imaging today, I'm going to be talking about in vivo imaging, but you'll just have to forgive my my ignorance on ignoring the multitude of other imaging types. So yeah, so we focus on PET imaging of the immune system, specifically or mostly in cancer, and that's what I'm going to talk about today. I do have one relevant disclosure, which is I'm a co-founder of Cytosite Biopharma, which is licensed the Granzyme B PET probe that I'll be talking about today. So just to jump in, I realize you guys are a very diverse group. So to give just a brief background on immunotherapy for those who aren't in the cancer field, it's really been a treatment that's revolutionized cancer therapy. And it's been able to produce these remarkable, durable responses in very hard to treat cancers like stage 4 melanoma and non-small cell lung cancer. But despite these successes, the reality is that most patients are not going to benefit from immunotherapy. And this is a problem, one, because these therapies are very expensive, but more importantly, these therapies can come with some pretty severe side effects, and they can even, you know, include death. And so while as an oncologist or a patient, you know, everybody wants to have this shot at these remarkable, durable responses, we need the ability to be able to monitor treatment and pivot from immunotherapy to other types of therapy or clinical trials as quickly as possible to avoid the side effects and the ineffective treatment. So this is confounded by the fact that we as radiologists actually have a very hard time in monitoring response to immunotherapy. Typically, tumor response is measured either using CT to take the actual volume of the tumor, or by measuring uptake of radioactive glucose called FDG using a PET scanner. And both of these things are not very good at determining response, mostly because immunotherapy can take a while to shrink tumors. And in some rare cases, immunotherapy can actually make tumors grow larger temporarily. And the other method, radioactive glucose, that is usually used to detect cancer, when the immune cells are activated, they also take up more radioactive glucose, which means that even responding tumors can appear to have no change in size or no change in FDG, or even go up, even though eventually they will respond. So our group is focused on looking at the biology of immune response in order to develop new biomarkers that can predict or determine early during the course of treatment whether the immunotherapy is going to be effective on an individual basis, and then expand that to combine with more tissue-based analysis to then start answering the question of why do some patients respond to immunotherapy and others do not. I've always borrowed a term that you know, I think pathology has really pioneered, which is the precision medicine term. Pathology has really revolutionized cancer treatment, and I don't need to tell you guys that tissue-based sampling is extremely powerful and has led to tremendous insight, has changed clinical practice, and it, the ability to monitor thousands of proteins or genes is just a really powerful technique. But tissue-based sampling, it does have a limitation, And namely, it is that it's invasive. So in the case of cancer, you're going to be taking a biopsy, which is going to be just one portion of a single tumor. And if you're talking about metastatic disease, you're not going to be able to sample every metastasis. And we know that tumors are heterogeneous and that metastases can be heterogeneous. And the second limitation is that, obviously places like UAB can do multiple time point biopsies, but most patients are going to be, having a biopsy taken at a single time point, usually before treatment. And we know that tumors, as they progress, they can change their phenotype. We know that metastases can be different than, can also change. We know that the addition of treatment can also change tumors as well. So this is where I think imaging can be really complementary to tissue-based sampling, because imaging is whole body. So we can look at not only the entire tumor, but also all of the metastases in the body simultaneously. And because it's non-invasive, we can monitor tumors before treatment and then go in and recheck them after treatment as well. But imaging has its own limitation, and that is because of the way the in vivo imaging works, in the PET imaging, we can only monitor a single target at a time. And this is because typically what you will do when you have a PET scan is you will take your patient and you will inject them with a radioactive imaging agent. This imaging agent typically consists of a targeting moiety connected in some way to a radioactive isotope. In the case of PET, this radioactive isotope is going to emit a positron, which is going to travel out of the nucleus, hit an electron, and annihilate. When this annihilation occurs, it emits two 180-degree coincident gamma rays. And it's these 180-degree coincident gamma rays that allow us to actually detect where the radioactivity is when we put the patient inside of a PET scanner. And so this technology allows us to very accurately quantify the spatial localization and of the target, but we can only radio label one targeting moiety and inject it at a time. So the choice of target is really critical, and that's that's where a lot of my research focuses is trying to pick targets and then validate them in vivo before moving them, or validate them in preclinical models before moving them into the clinic. So with that background on PET imaging and what we're trying to do, we focus on the tumor immune microenvironment, and I love this this figure from my neighbor here at the Wallace Tumor Institute that really divides the tumor microenvironment in regards to the immune system into two separate and opposing forces. On the left, you have the anti-tumor inflammatory response that is responsible for controlling tumors, and then on the right you have the pro-tumorigenic immune suppressive microenvironment. So when you begin to think about what are the important factors to monitor in these two separate microenvironments, you can focus on things like the cell types that are present, effector cells or macrophages controlling the tumor, or regulatory T cells or alternatively activated macrophages that promote tumorigenesis. You can also think about effector molecules like cytokines or other Granzyme B or things that directly elicit cell killing, and also cytokines that are more suppressive or other physiological factors that contribute to a suppressive microenvironment. And so I'm going to divide my talk today into these two subsections. We're doing imaging that we hope addresses both of these, and that's how we'll kind of continue. So the first part is going to focus on immune suppression. And one of the most suppressive features of tumors is hypoxia. And it's been known for a long time that as tumors progress, they generally become hypoxic, either due to aberrant vasculature, or even physical pressure, preventing oxygenation of the tumor. And hypoxia is, it really dampens the effect of almost all therapies: chemotherapy, radiation therapy, and of course, immunotherapy. And so we know that hypoxia is bad. And there's been a lot of research focusing on methods to reverse hypoxia or improve tumor oxygenation in order to improve immunotherapy response. So there are, there is a push towards combating hypoxia that we hope to take advantage of. Specifically, if we talk about hypoxia in terms of an immune response, it's kind of bad across the board. It affects macrophages, natural killer cells. It increases Tregs, decreases effector T cells, decreases MHC expression, and increases a whole host of checkpoints that really act to put a brake on the anti-tumor response. So it makes it very difficult to target any one of these individual things that hypoxia elicits, and really makes it, sort of a battle of, are you treating the symptoms or are you treating the root cause of immune suppression? Surprisingly, even though it's generally well accepted that hypoxia would hinder immunotherapy, there are actually very few clinical trials that combine hypoxia monitoring with immunotherapy. And so, despite this pretty strong evidence, this correlation hasn't been extensively investigated, and that's where we tried to jump in and apply some of the in vivo imaging techniques that we use to combat this problem. So hypoxia has been able to be imaged using PET imaging for quite some time. And most of the PET imaging relies on injecting radioactive tracers that are trapped inside of hypoxic cells. And there's a whole host of these that have been utilized clinically, and most of them compare pretty well to invasive measures like polarigraphic oxygenation or some of the surrogate markers that can be stained for by IHC. But where we think that imaging can play a significant role is that because tumors, as they progress, can become more hypoxic, or as they're treated, can become less hypoxic, the need to longitudinally monitor hypoxia is very great. And that's where the non-invasive nature of PET imaging can really be utilized to monitor changes in hypoxia over time. So this work is a collaboration between my group and Dr. Anna Ceresi's group that focuses on using one of these tracers called FMISO to perform PET imaging. And the hypothesis was that this PET imaging would identify unfavorable immune microenvironments. So what we did to start out this project was we used sort of a standard syngeneic model of cancer, and then performed PET imaging both prior to the initiation of immunotherapy and then after the initiation of immunotherapy. And when we did this, we could identify tumors that became hypoxic. You can see here the white arrow is pointing to the tumor. So you can see a baseline level of hypoxia, and then after treatment, the tumor becomes more red in color, which denotes more hypoxia. And this can be differentiated from tumors that have a baseline level of hypoxia, shown here, that actually decreases over time. And so, using PET imaging, we can bucket these mice into either hypoxic tumors or normoxic tumors. And the beauty of doing non-invasive imaging is that we can then track these tumors over time and monitor how these biomarkers correlate with response. So if we do this, unsurprisingly, if we look at something like triple-negative breast cancer, you can see that hypoxic tumors respond very poorly to immunotherapy, and as opposed to the normoxic tumors, which are well controlled using immunotherapy. And if you move this to a different type of tumor, colon cancer tumor, you see the same sort of effect in increased tumor growth in the hypoxic tumors. And of course, unsurprisingly, this correlates to a survival benefit as well, where normoxic tumors have higher overall survival, both in the triple negative and in the colon cancer. And so, the PET imaging showed that the uptake of the tracer correlated well with response. But we wanted to take it a step further then and actually look at if there were phenotypes associated with PET imaging uptake that would support a more active immune microenvironment in the normoxic tumors in comparison to the hypoxic tumors. And so, first we had to set sort of a threshold that we would use to subdivide these tumors. And so if we inverted our comparison and looked at tumors that responded to immunotherapy versus tumors that did not respond to immunotherapy, we could see that in non-responders, there was a marked increase in hypoxia that occurred over time that wasn't present in the responders to immunotherapy. And furthermore, we could look at tumor volume and see that this change in hypoxia was not dependent on tumor volume. And so the tracer wasn't being non-specifically taken up into larger tumors, which can sometimes be a problem in vivo imaging, just due to the larger size and increased sort of permeability of the blood vessels in very large tumors. So we were pretty confident that we had sort of an accurate metric to start dividing these tumors up and start doing tissue-based analysis. And so what we did next was we did the PET imaging and bucketed them into normoxic and hypoxic tumors, and then used nanostring immune profiling to look at the immune phenotypes of these different tumors. And just using phylogenetic clustering, you can see that a lot of these normoxic tumors had a highly enriched immune activation phenotype that was pretty robust, sort of across a number of different measures, whether it was looking at adaptive pathways or chemokines. And these pathways resulted in increased levels of infiltrating T cells and macrophages and dendritic cells. And interestingly, if you looked at it relative to the total immune cell infiltration, while cytotoxic T cells weren't enriched per se, there were in hypoxic tumors more exhausted CD8 T cells, and in the normoxic tumor had more dendritic cells. The hypoxic tumors really had less of these. And these phenotypes were observed both in the triple negative breast cancer as well as the colorectal tumors. And so we thought that there was pretty strong evidence that this hypoxia imaging was correlating with an immune activated phenotype. So the next step, after sort of confirming that hypoxia PET imaging could really identify these biologically distinct tumor microenvironments, was to use PET imaging in a personalized way to actually guide immunotherapy. And so we started with the premise that hypoxic tumors were not going to respond to immunotherapy. And so those were the tumors that we really wanted to focus on in terms of improving their overall response. And so as we dug into ways to sort of combat this hypoxia, we discovered that there's a clinically utilized hypoxia targeted prodrug called ivofosfamide that actually uses the same mechanism that our PET imaging agent uses, but it is in itself, when it undergoes reduction, it becomes a chemotherapy. And unfortunately, in the clinical trials it had been used in, the patients hadn't been stratified for hypoxia. And so most of the clinical trials had been unsuccessful. There's actually a very recent clinical trial that just came out, I think in the last week, from Aparna Hegde, who's here at UAB, from her time at MD Anderson, where they combined ivofosfamide with ipilimumab, which is a CTLA-4 targeting immunotherapy. And that trial showed some promise, but it still wasn't wasn't stratified based on any measures of hypoxia. So we sort of developed two hypotheses off of these, or two questions we wanted to ask. And the first was, could PET imaging identify tumors that would be responsive to hypoxia-targeted therapy? And then could targeting this hypoxia actually improve response to immunotherapy? So if we started to try to tackle this question, if we just have the normal growth of a tumor looks like this, and if we don't subdivide the tumors based on hypoxia and we add evofosfamide, we really don't get any response. It might be slightly worse, but statistically it's roughly the same. There's no difference in tumor growth between evofosfamide and just normal tumor growth. But of course, that's not what we wanted to do. What we wanted to do was perform PET imaging, stratify these tumors as normoxic or hypoxic, and then personalize, tailor the treatment towards the hypoxic tumors to add evofosfamide in combination with immunotherapy. And so, unsurprisingly, if we added immunotherapy to normoxic tumors, they did very well in comparison to the vehicle. And if we added immunotherapy to hypoxic tumors, they had no benefit of adding in immunotherapy to them. But what's been really exciting for us is that if we add in evofosfamide to these hypoxic tumors, we get responses that are essentially equivalent to if we added immunotherapy to normoxic tumors. And this is also seen as a increase in overall survival of these mice, and really has provided strong rationale to begin to investigate this clinically as well as a potential mechanism to rescue these tumor types that would otherwise not be able to benefit from immunotherapy. So, I think right now we're at the point where, at least preclinically, we think hypoxia is a valuable tool for identifying these favorable tumor microenvironments, and we can add hypoxia-targeted prodrugs to this. And so this has spawned Dr. Ceresi to begin a clinical trial, because the beauty of both this FMISO-PET tracer and evofosfamide is that they're both clinically utilized. So she is starting a clinical trial in triple-negative breast cancer, where she's going to perform PET imaging both pre and post immunotherapy, and then do kind of like what we did in the mice. First, understand if the hypoxia uptake correlates with response to immunotherapy, and then obviously later on down the road, but the ultimate goal of this is to use the hypoxia PET imaging to personalize the oncology treatment through the addition of something like evofosfamide, to try to elicit the same sorts of rescue that we saw in the mouse models. And so, very excited to get this underway. I think the protocol was just approved, and so really looking forward to seeing how this fares in the clinic. So switching gears a little bit and moving to immune activation. I started this research back in my postdoc about 5 years ago, and this was a little bit more difficult in terms of determining the right biomarker for response to immunotherapy. A lot of thought was when 5 years ago, and still some to this day, was that in general, tumors with higher levels of T cells were going to be more responsive to immunotherapy. And when we were thinking about if that would make the most sense as a PET tracer, we wanted to sort of confirm this, at least in models, before we really went whole hog into designing PET tracers, because designing targeting agents from scratch is a long and arduous process, and you really want to make sure that your target is the one you want to be targeting, because of the limitations that I've talked about for PET imaging. And so when we started, we looked at just a model of colon cancer and compared treated and untreated tumors at several different days. And we were surprised to see that in these models, there weren't huge differences in the levels of CD8 T cells or CD3 T cells between even the treated and the untreated mice. But fortunately, we were looking at other markers, and one of them was this protein Granzyme B. And we were really happy to see that not only was there a difference, as you can see here, early on, there's one tumor that has more Granzyme B, and then as you progress through time, you get higher and higher levels of Granzyme B. So there's a differential between the treated and the untreated tumors. But just as importantly, we knew that just like in humans, in these mouse models, not all mice were going to respond to immunotherapy. And so we were excited to see that there were some treated tumors that had high levels of Granzyme B and some treated tumors that had lower levels of Granzyme B. And when we looked at this in a little bit different mechanism, looking at it spatially, we saw the same sort of thing where the amount of T cells between an untreated and a treated tumor was roughly equivalent. And even if we looked at the Granzyme B, it sort of had two staining patterns. One, these little punctate spots that co-aligned with the T cells. And there wasn't a huge difference between those, but where there was a real difference were these larger splotches of Granzyme B that correlated to the release of Granzyme B from T cells. And this is where the tumors really differentiated. And so if you think about the biology of how an effector T cell actually kills a tumor, the T cell infiltrates the tumor, recognizes its specific antigen, and these T cells are filled with these granules that have both Granzyme B and another protein called perforin. And when it recognizes its antigen and gets an activating signal, it releases these granules, and the perforin allows the Granzyme B to infiltrate the tumor cell and elicit cell killing. So we thought, if we could image this Granzyme B, then we could effectively image tumor cell killing. And so that's what we set out to do. So fortunately, for designing this PET imaging agent, there were crystal structures and other work that allowed us to rationally design an imaging agent, and the structure is shown here. And I'm not a chemist, so I won't belabor it too much, but essentially the business end of the molecule is on the right here. It's a peptide that binds in the active site of Granzyme B, and it's modified with this aldehyde that allows it to irreversibly bind in the active site of Granzyme B and sort of stick there. And then on the left side, we modify it with this molecule. It's called a chelator. This chelator allows us to stick a radioactive metal called gallium-68 into the center here. And then that allows us to track where this molecule goes when we inject it in vivo. So we made this molecule and first just did some in vitro testing to show that it did bind to Granzyme B with high affinity. And it was specific for Granzyme B in comparison to other granzymes. And so, we knew at least in vitro that we had a pretty good molecule. So the next step was to take this in vivo. So the way we sort of set up this model is that on day 0, we inoculate a tumor. And then we initiate treatment with the mouse version of a clinically relevant combination that targets PD-1 and CTLA-4. And we choose this treatment model because it allows us to get a good mixture of tumors that respond to immunotherapy and tumors that don't respond to immunotherapy. And then what we started out with was just imaging on day 14, which, if you remember from the Western blot, there were multiple tumors with high levels of Granzyme B. And then after imaging, we did ex vivo analysis to confirm that the PET signal correlated with actual expression of Granzyme B. So when we performed this PET imaging, we were really excited because as you can see in the immunotherapy treated cohort, we get nice uptake of the PET tracer that is not present in the vehicle treated tumors. And then if we cut out these tumors and correlate the PET signal, which we quantify as something called TBR, which is just a tumor to blood ratio, measure of specificity of the uptake, we got a pretty strong correlation between Granzyme B protein and Granzyme B PET signal. So we knew that Granzyme B or our PET tracer at least correlated well with Granzyme B, but of course the question remained, did Granzyme B correlate well with response? So this time we went back to the model, treated it the same. This time we moved the imaging day up 2 days. And this was so that at the time of imaging, all of the tumors would be roughly the same size and volume. So we would have no real indicators of response, and we could make an accurate judgment of whether we could predict response. And so when you image these treated mice, even though they're genetically identical mice, given the exact same tumor and the exact same treatment, some mice have high levels of Granzyme B in their tumor, and some mice have low levels of Granzyme B in their tumor that look a lot like vehicle-treated mice. And we do this imaging on day 12, where all of the tumors have the exact same tumor volume. So the only way you can differentiate them is by looking on the PET scan and seeing that the levels of Granzyme B differ between these mice. And what we were really excited about, and what you can see, is that those with high Granzyme B that are colored green, by day 18, resolve, and those with low Granzyme B grow and are similar to the vehicle. And so, we were really excited that this PET tracer was predictive of immunotherapy and had this great potential, and started to go out and present it, and got some really interesting questions of, that we needed to answer to really prove to ourselves that the PET tracer was actually accurately quantifying Granzyme B, and Granzyme B was the thing that was the biomarker for response. One of them was, how do you know that responders don't have just non-specific more increase of the tracer over time? And the cool thing about PET imaging is that you can measure the levels of Granzyme B continuously from injection. And you can see that in responders, we get this increase of signal that increases over time. Whereas in non-responders, you get early delivery of the tracer, but over time, because there's no Granzyme B present, the tracer washes out. And so dynamically, you can see that it's not a delivery mechanism that's increasing the amount of Granzyme B. It is specific retention. The other way that we sort of confirmed this was to use these mice, and because the PET imaging, the signal decays, and it decays very quickly. So you can image these mice in the morning, and by the afternoon, they're no longer radioactive, and you could actually image them again. And so that's what we did. We took our peptide, and then we scrambled it, made a control version of the peptide, and we divided the mice in half. And in the morning, half of them got the targeted peptide and half of them got the scrambled peptide. And then in the afternoon, we reversed. And what we could see was that in the responding mice, only when we injected the targeted peptide would we see high accumulation of our probe. And if we injected in the exact same mice, exact same day, a non-targeted version of the peptide, you would get no uptake. I mean, we could do this with multiple different peptides. And so, we were really convinced that the uptake that we were seeing was driven by the levels of this Granzyme B, and really correlated. That was what was correlating with response. So then, all of this was done in a single model with a single type of treatment. The question was, would this be relevant to other models, both other cancer models and other treatments? And then, other things would be, could it be used to compare combination therapies? Could it be used to look at the timing of therapy? And could it be used to to identify what was driving, these differences in response between these genetically identical mice. So the first thing was, could it be, was it applicable across models? So this time we did the same treatment days, but added in a bunch of different therapies, and added in a second tumor model, and then did our imaging again the same way and monitored response. And this slide's pretty busy, but the takeaway message is, even across different tumor models and with different treatment types, mice with high levels of Granzyme B responded to treatment, and mice with low levels of Granzyme B did not. It wasn't perfect like it was in the first model, but it still had, very high sensitivity and specificity as we expanded. And we started to see other interesting trends that came out of this imaging as we expanded groups. And one of them was, if you, instead of looking at an individual tumor level, if you averaged all of the tumors across the groups, you started to see these correlations where, as a group, if your uptake was higher, then the group level response was also higher. And so this was interesting in two ways. One, because we used two different models. One was a CT26 that was moderately immunogenic, and the other was this MC38, which is this microsatellite unstable colorectal model that was highly immunogenic. And even if at baseline, or if you didn't add any treatment, there was a significant difference in the group level of Granzyme B, which correlated the more inflammatory tumor had higher levels of baseline Granzyme B. And then if you correlated the different treatment averages with the different overall responses, you got actually a pretty tight linear correlation between higher group levels of Granzyme B and higher response rates. And so, this has potential implications for monitoring different combinations of therapy, because if you have to wait for progression-free survival or overall survival in these, the clinical trials can take a long time. And if you want to do early stage rapid comparisons of different combinations, this PET tracer may have some value. The next thing we wanted to look at was therapy scheduling, and this gets into the side effects that I talked about earlier, where right now combination immunotherapy is given concurrently, and there's biological rationale that this may not be the best approach, and may lead to more side effects, and not necessarily more efficacy than if you were to give one immunotherapy targeting CTLA-4 first, and then follow it up with PD-1 immunotherapy after that. And again, traditionally, if you were to run this clinical trial, you'd have to do it with long outcome-based things. And so we asked, could Granzyme B PET imaging be used as a surrogate marker of this, to sort of parse out whether this is a good avenue to explore. So in this model, we did treatment, but we varied the schedule, like I said. So one group of mice got the standard concurrent PD-1 and CTLA-4 therapy. One group got CTLA-4 therapy just once, and then maintenance PD-1 therapy. And then one group got concurrent once, and then maintenance PD-1 therapy. And then we did imaging and monitored response. And so when we did this imaging, what we saw first was that there was no difference in the level of Granzyme B across any of these different schedules. So it didn't appear, at least from a PET imaging perspective, that one was more effective than the other, and they all were more effective than vehicle. And when we started to measure changes in tumor volume, we saw that there was no difference between any of these therapies in terms of tumor volume, and they were all more effective than vehicle only. And this held across the overall survival of the tumors as well. And so all of this sort of suggested that that Granzyme B could be used in a manner of analyzing different combinations or different schedules of these combinations of immunotherapy also. So another interesting potential avenue for exploration. All of the work so far has been checkpoint inhibitor and even a specific CTLA-4 and PD-1 checkpoint inhibitor, but these aren't the only immunotherapies out there. And there's this whole focus on these adoptive cell transfers where you either take a patient's own T cells and alter them to be more tumor specific and then re-inject them, or use off-the-shelf T cells that are specific for different tumor biomarkers. And this is a really active and promising area of research. And because they typically use T cells, we thought that Granzyme B could be a good way of sort of monitoring the effectiveness of these T cells. So we worked with some collaborators out in Munich who had a tumor model that used an artificial antigen, ovalbumin, that they had pancreatic tumors that were either had or did not, had a mock transfection or had the antigen expressed, and then they had T cells that were specific for this ovalbumin antigen. They were interested in they sort of supercharged one set of T cells by overexpressing CXCR6, and the other set were just ovalbumin specific T cells without the CXCR6. We were just interested in whether we could image, the response to this adoptive cell transfer. But we looked at both groups, and the mice had on one side the ovalbumin tumor, and the other side the control tumor, and we did longitudinal PET imaging after injection of the T cells. And so when we did this, it was really, really interesting. So you can see that in the tumors that express the antigen, we see higher levels of Granzyme B as compared to the tumors that do not express the antigen. And it appears that the supercharging of the T cells induced higher levels of Granzyme B as compared to the mock transfected T cells. But the mock ones still had some activation, but not as robust of activation as the CXCR6 transfected ones. And we can monitor these over time and see that it looks like the CXCR6 was driving higher initial levels of activation, and that the kinetics of activation was actually quite similar between the two T cells after that. And so, that was interesting information about what was driving the higher levels of Granzyme B. And you could see that in the non-antigen expressing models, we had a pretty flat level and baseline level of Granzyme B. Of course, we could break these down into individual mice and see that most mice, sort of had the same kinetics over time in the targeted tumors and the pancreatic tumors. And one of the interesting side notes that we noted from this that our collaborators weren't as excited about as we were was that you can see here in the picture that there appears to be higher liver uptake in the CXCR6 expressing T cells as opposed to the mock transfected T cells. And when we quantified it, you could see that there was similar levels, maybe slightly elevated initially, but that over time the level of Granzyme B increased significantly in the liver. And it turns out the liver expressed a ligand for CXCR6, and so this was sort of an on-target, off-tumor side effect of these T cells, but goes to show that the Granzyme B could also potentially be used for looking at immune-related adverse events from different therapies as well. So all of these were sort of biomarker-based prediction type studies, but they didn't get and they could be used to determine who would respond and who wouldn't respond, but they wouldn't help us answer the question of how do we get more people to respond to immunotherapy. And so we wanted to. This is where another place where we think imaging can match up well with pathology, and that's because typically a lot of these studies that look at biomarkers are taken at a specific time point and then analyzed and bucketed based on responses that occur much later. But this doesn't take into account things like, in responding tumors, how do we know at the time of biopsy that the tumor was responding? Or on the flip side, what if there was an initial response, but it was insufficient to clear the tumor? And so Granzyme B PET imaging could be used to give functional information at the exact time of biopsy, and then provide a functional correlate to put these all of the different biomarkers that you can assess into context. So what we did was we again did this PET imaging, and this time, instead of tracking response, we cut out the tumor in the draining lymph node immediately after the PET imaging. We generated single cells for flow cytometry. We collected supernatants for cytokine analysis. Then we correlated the PET signal with these different biomarkers. And so when we did this across 2 different models. We were really surprised in that there were actually very few cell phenotypes by flow cytometry that correlated with response. And most of it was actually correlated with non-response and had a lot to do with sort of the different antigen presenting cells that were present in the tumor. But fortunately, we also collected these cytokines, and what we saw was that there were a number of pro-inflammatory cytokines that correlated very strongly with Granzyme B, and could be thought, could be used to potentially supplement immunotherapy or used to design different mechanisms to elicit higher levels of response. So this was very interesting and sort of gave a picture of how the PET imaging could be used to personalize treatment in the mice. But of course, we didn't see, there wasn't a ton of, or there was some overlap, but not enough to really say that there was a universal mechanism of response in these tumors. We aren't super interested in figuring out the best way to cure CT26 mouse cancer. But instead, what we're hoping to do is to translate this paradigm into humans, with the idea being that you have patients that all receive checkpoint inhibitor therapy. You do early on treatment Granzyme B PET scans, and then you can divide the patients into those with low Granzyme B and those with high Granzyme B. And then this is where you can really get synergistic effects, because you can use the histological analysis that can give you lots and lots of insight, and use that to design adaptive therapies that maybe combine radiation or a tumor vaccine or a different combination therapy, with the goal being to convert low Granzyme B tumors into high Granzyme B tumors, while those patients that are benefiting from Granzyme B or from immunotherapy can just remain on that immunotherapy and enjoy the benefits of response. So in the last little bit of time I have left, I'll talk a little bit about the translation of this imaging probe into the clinic, because all of this stuff has been preclinical so far. Of course, the goal, as always, is to generate something that has clinical benefit. And so we had to foray into pathology a little bit, and we're fortunate to work with some great surgeons that were able to get us some tissue. But the first problem we had to tackle was that the mouse Granzyme B and the human Granzyme B actually have slightly different substrate specificities. So we had to take our mouse imaging agent and convert it into a human imaging agent, which wasn't that hard and still relies on the same principles as the mouse. But then we also had to convert it from a PET imaging agent to something we could use for tissue analysis. So we switched the chelator to a biotin, and then began to work with tissues. So the first thing we had to do was make sure that Granzyme B was expressed in human tumors that were being treated with immunotherapy. And so, as you can see, there's in treated tumors, there is Granzyme B increases. And if we probe the same tissue with our peptide, we saw similar staining patterns between the antibody and the peptide. And if we did immunofluorescence, we could get pretty good co-localization of the signal between the peptide and the antibody. But of course, then the question remained, there is Granzyme B, but is the Granzyme B predictive? So now we took a bunch of different biopsy samples. They were all sampled at different time points. And this was retrospective, but we were blinded to the response. And we stained for Granzyme B. And what we could see was that there was a time-dependent increase in Granzyme B in responders that wasn't present really in non-responders. There were, of course, a few outliers, as there always are, but in general, higher levels of Granzyme B in responding tumors. To wrap this up, I think that, it looks like Granzyme B has potential to be a useful biomarker, and we have a good peptide tracer for it, and it works well in mouse models. Really excited that the phase 1 trial, looking first at safety, but also we have some efficacy time points, is open at UAB, and we've actually been fortunate enough to image multiple patients. Unfortunately, I can't share the images today, but hopefully soon I can show it. But the results look preliminarily promising. Obviously, it's very early on, so it's hard to say how it's going to turn out. But I have been fortunate to get some funding from the NIH to expand these clinical trials and look at different tumor types, and also combine the PET imaging like we're doing like we did in the mouse models in the human trials as well, to look at correlations between PET signal and different histologies and things like that. Actively seeking collaborations, and you guys would be a phenomenal partner for anybody who's interested in looking at combining sort of expertise. So with that, I want to thank everybody from my lab who's worked on this, and then Anna Ceresi, who's been a strong collaborator on the hypoxia work, and then clinically, getting this clinical trial up and running. The cyclotron facility is just awesome, and other collaborators as well with the nanostring, Dr. Yang, and then outside collaborators as well. And funding is always super important. So the NIH, some of the internal, the Mary Ann Harvard Award here from the Cancer Center, and the Pittman Scholar as well. And with that, I'd be happy to take any questions. Thank you.
Ben, thank you. That was excellent. It looks like we'll have to plan on having you back next year so you can tell us about that clinical trial. Very impressive work.
Sounds wonderful.
So we're open to questions now. Yes. Just if you want to unmute yourself and ask your question. Maitri?
Yeah, hi, Ben, this is Maitri. Can you hear me?
Yep.
Sorry, my camera is not on today. Great talk, and I'm sorry I've missed some of your earlier seminars, and I regret that. So I have a quick question about that first study that you have with the FMISO-PET imaging.
Yeah.
So in the clinical trials, I was curious, is that being done as a combination with FDG-PET, or just is the FMISO-PET on its own that great?
So it is, so the patients will still receive their standard of care. So they'll still be getting their FDG PET
Okay,
scans.
I missed that.
The FDG is going to be obviously used for staging and all of that, and in some treatment response monitoring. But whether FMISO is good it won't be good by itself for detection. That is for sure. But in terms of stratifying for immunotherapy response. Hopefully it is, but I guess the clinical trial will give us definitive, or at least a clue as to whether that works.
Yeah, that's pretty exciting. So thank you. Yeah.
Hey, Ben, just continuing the conversation on hypoxia further, and I can, after this talk, I'm going to just run over and continue this conversation. But if I don't ask now, I'll forget it. So why is FMISO better than, something like HX4, which, I mean, it seems to be just as well received in the imaging field for hypoxia?
Yep. It is not better. So it is better from a practical standpoint only. I think that HX4 is at least equally as well received. One of the interesting things that we think, that we're hypothesizing about FMISO is that it's actually going to only be taken up in very hypoxic tumors, whereas HX4 may be taken up in only moderately hypoxic tumors. And so it may be that this actually gives us a little bit of benefit where we're only looking at the, what we're calling hypoxic is very hypoxic as opposed to just moderately hypoxic. But HX4 could end up being a better tracer. We have immediate access to FMISO right now. HX4 would require, getting permission from, the other IND holders and would just delay doing the trial by at least a year. And so the idea is to get some preliminary hypoxia data. And then, we're not married to FMISO in any way. We think hypoxia is really exciting and want to get clinical data as quickly as possible.
All right, thanks.
Hey, Ben, this is Rajiv. Fantastic presentation.
Thank you.
And as you know, we keep chatting on hypoxia once in a while. So this is, so in tumor, actually, hypoxia will be dynamic. I mean, what you image one day may not be true the next week or next day even. So that's my perspective. So how do you address that?
That's a great question. I think that one of the things would be, so we're able to do multiple imaging time points, and we're trying to tie them in with as closely to the time of treatment as possible. And so I guess the question that would be that we couldn't, while we can do multiple imaging time points, we can't obviously image every day for a number of practical reasons. So we'll have to that'll be something we'll have to investigate. It may be that while hypoxia varies, maybe the standard deviation of variation goes down over time in responders, so that you can get a threshold. But honestly, it's a great question that we hadn't really considered before, and it's something that maybe we can talk with you about. If you have any thoughts on ways to sort of mitigate that, for the trial.
Sure, thanks.
Hi, thank you. Fascinating talk. Wanted to ask you, as far as side effects of immune checkpoint inhibitors, do we know, for example, if a patient has myocarditis as a side effect, is Granzyme B increased in the heart? If he has colitis, increase in the colon and so on. So is Granzyme B also involved in side effects as it is in the anti-tumor effect?
So we don't know yet. In colitis, there have been people that have shown that non-checkpoint induced colitis, but colitis in general, does have Granzyme B. I would hypothesize that it is. And for example, in one of the patients that we imaged, so in all of the patients that we imaged, there's very low uptake in normal tissue. In one of the patients we imaged, there's a small section of the colon that has high Granzyme B. This patient was just imaged 2 weeks ago, so we don't know if that's going to correlate with colitis, but we think that it might, or that it mechanistically it would make sense, but right now we don't have the evidence to support that. But it's something that we'll be looking at. And the beauty of the PET scan is that for every patient we do, we get the whole body, and so prospectively, we can't make a prediction, but we can retrospectively go back potentially and at least use that data to support future prospective trials.
So we are past the hour. I know people are dropping off if they have other things to do. I did have one additional question about the first part of your talk and this whole hypoxia question. From the discovery standpoint, how often are you able to do co-imaging or the serial imaging that you were discussing to look at the metabolic environment of these hypoxic tumors? And I ask because I personally am very interested in metabolic substrate switching. So can you show that in the hypoxic environment that those tumors are more glycolytic and less reliant on fatty acids or other metabolites?
Yeah, so in the mice, we could practically we're limited by how many times the tail can take a tail vein injection. So we could do, if you wanted to do it daily, we could probably do daily for 3 or 4 days. If you wanted to do it every 3 days, we could do every 3 days for up to 2 weeks. The amount of radioactivity that we inject into these mice is very low, and so they're pretty well able to tolerate it. It's more how many times can their tail get stuck with this before you start to get some problems.
Okay, cool. Thank you so much, and I'll follow up with you later. But thank you again for presenting.
And if anybody wants to, I'm around. I shoot me an email or whatever. I'm super happy to discuss.
Great. Well, thank you again.
Awesome. Thanks, guys.